Okay, hello friends. Today we are going to start the new chapter, new section of cardiovascular physiology. We have finished in the previous videos the hemodynamics part of the cardiovascular physiology. It's incumbent and important for the people who are watching this video to watch the hemodynamic part first to understand the cardiac mechanics better. Okay, so let us I hope the screen is clear and it's visible. So I want to go take you to some part of the cardiac part. Now see, you will be coming across some terminologies which want to make it clear today only. Okay, now you may have come across some words such as cardiac cycle. You may have come across some words called systole, diastole. Okay, you may have come across some words called heart sounds. You may have come across the words S1, S2, S3, S4. You may have come across or you may have not come across. That's a different question, but we have to learn all these things. Okay. Or you may have come across some pressure loops, volume loops. Okay. So what actually, understanding basics is important to reach a diagnosis, isn't it? Understanding basics is important to reach a diagnosis. I want to make first some terminologies clear. Now see, cardiac cycle is a big topic which I will be teaching you. But first I want to give you a concept, that is cardiac cycle is equal to systole plus. Now I was telling you systole plus diastole will give you what? It will give you the cardiac cycle. That means you have to know the systole. That means you have to know the diastole. Now systole, or sometimes I don't know, some people speak systole. Okay, so systole is a part of a cardiac cycle. Diastole is a part of a cardiac cycle. Systole is that part of cardiac cycle. Please remember two words. We have people who have lost basics and they are just treating, about skies. I don't know where the treatment is coming from. Okay. Once I ask, even my HOD sometimes back asked me, what is systole? What I said it is contraction. Incomplete answer. Systole means contraction and ejection, not erection, ejection. Okay. So systole is contraction, ejection. Contraction, ejection, systole. So systole is the part of the cardiac cycle in which the heart is contracting and ejecting the blood. Contraction of heart musculature and ejection of the blood. Okay. If I say this systole can be divided into two, okay, it can be divided into two. One is atrial systole, one is ventricular systole. Now orientation is here. I have 4 chambers of the heart, because on the chambers logo I have 4 chambers of the heart, isn't it? Now this is your right atrium. Orientation, right ventricle, left atrium, left ventricle. Fine. Now if right atrium is contracting, I say right atrial systole or atrial systole. For example, these atria are contracting, I will say atrial systole. If ventricles are contracting, I will say ventricular systole. Or I can say atrial contraction or ventricular contraction. That means atrial systole will pump the blood in the diastolic ventricles. Now I will be telling you the meaning. First I want to tell you atrial systole, ventricular systole, atrial systole, ventricular systole. Fine. When is the blood pressure going to be high out of these two? Blood pressure is going to be high during this phase. What? Systolic phase. Remember, I want to tell you about the systolic phase. Blood pressure, what is important about the systolic phase? The blood pressure is going to be highest. I'm not saying high, highest. That's why we call this blood pressure is also known as systolic blood pressure, SBP. Systolic blood pressure is called SBP. Three things we learned. One thing, systole, contraction, ejection. Two, systole can be according to the person who is doing systole. Atria is doing systole, atrial systole. Ventricle is doing systole, ventricular systole. Atrial systole, ventricular systole. Blood pressure is high out of these two. Where is the blood pressure high? Systole or diastole? Systole is having the highest blood pressure. What is the systole? What is the blood pressure in systole known as? Systolic blood pressure. Fine. Going to the diastole. Diastole is also a part of cardiac cycle. If this was about contraction, ejection, diastole is about relaxation and filling. Relaxation, filling. Relaxation and filling. It's about relaxation and filling. Filling what? Filling with blood. That means if you want to fill something, what do? You have to increase the volume of that area. You have to increase the space so that the things can come in. If you give me a stick and you tell me to fill it, you give me a stick and tell me to fill it with water. How can I fill it with water? It's all in contracted phase. It's all in a there is no volume, there is no area, there is no space where I can fill the blood. But if you give me a utensil or a cup and tell me to fill it with blood, I will say yes. Easily I can fill it with blood because that has some area, that has some volume. You may be thinking, sir, why are you saying these simple things? I am actually teaching you medicine with this. If you can take my word to word in your brain, what I mean to say, that means he is also keeping in his mind some diseases where filling is not happening, where we don't have cups, where we have small cups. So you should not take it something that he is teaching so basic. Okay, there is a depth when I speak something. Okay, so diastole is that part of the cardiac cycle which is showing us relaxation and filling with the blood. Now, if blood pressure is highest during systole, when should be the blood pressure lowest? In the diastole. So blood pressure should be lowest in the diastole. Blood pressure should be lowest in the diastole, isn't it? What is the blood pressure in the diastole known as? Diastolic blood pressure, DPB, DBP, DBP. Systolic blood pressure, SBP. Diastolic blood pressure, DBP, DBP. Now, if I do one thing, I wanted to say you something. If atria is doing contraction, I say atrial systole. That means, what is the meaning of this? It's not only contraction. That means atria is pumping. So if I take, first I should give you orientation. It's not that we should fly. We know everything and then no. Everything should be from the basics. Atria. Make it clean so that no doubt remains there. Now see guys, if I want to show with this marker, let me take a red. See guys, when atria is contracting, I will say atrial systole, atrial systole. That means the valves should open, the valves, atrioventricular valves, they should open and fill these regions with blood. Fill these regions with blood. That means systolic atria are filling the diastolic ventricles. systolic atria are filling the diastolic ventricles. If any one of you gets a question, what is the purpose of keeping one in systole, one is diastole? What is the purpose of keeping one? Diastole is relaxation, isn't it? Relax means open. Relax means open, I want to fill. So if any one of you gets a question, what is the purpose of having systole and diastole at an alternate? Why one needs to be in a systolic phase and lower regions need to be in a diastolic phase? For the purpose of filling and for the purpose of effective ejection. For the purpose of effective ejection. If you give an effective relaxation, I can effectively fill you. If you give me effective relaxation, I can effectively fill you. And if I can effectively fill you, you can effectively eject blood to the systems. You can give a very nice blood supply to the systems. Is it fine? That is the basic philosophy. You should understand everything in detail. It's not that cramming, systole, diastole. Oh, what is the meaning? Because once you know the basics of this, then you can understand what is happening in a low output cardiac failure, what is happening in the high output cardiac failure, what is happening in atrial fibrillation, what is happening in supraventricular tachycardia, what is happening in paroxysmal supraventricular tachycardia. Okay, so go in a step-by-step manner. Now, in ventricular systole, what should happen? Ventricular systole, there should be no filling of the ventricle. There should be no filling of the ventricle. The ventricle should be only contracting against the closed valves so that all the blood can go through the vessels. Can we understand? All the blood can go through the vessels. All the blood can go through the vessels. Is it fine? And that will depend. Right ventricle is connected to which vessel and left ventricle is connected to which vessel. That is a secondary question. What is the main thing is to send blood out of eject the blood out of the heart. That is the ventricular systole. In ventricular systole, there should not be any filling. So every phase should go in a systemic manner. Fine. Now, atrial systole means atrial contraction means filling the relaxed ventricles. And ventricular and atrial diastole means atria is filled with blood. Atria is getting the venous return, that is atrial diastole. If I say ventricular systole, that means ventricle is ejecting the blood to the peripheral circulation, to the pulmonary circulation. And ventricular diastole means filling the ventricle with the blood coming from the atrium. That is, gates will open, dam will open, and both sided valves will open, and then simultaneously you will have filling of blood. It's all happening simultaneously. Don't take that right ventricle will first fill it with blood and left ventricle will get the blood. It's all opening. The channels are opening at the same time. These gates open at the same time, guys. Remember. So once you have to fill the ventricles, both gates open at the same time. I'll be telling you, it's not that same time also, but I will be telling you the splits and all that. But remember that it's happening more or less at the same time. Fine? Is it clear? Is it clear, friends, till this? Now, this concept is clear. There is no doubt. There is no doubt. Why we are going so basic? Because we have first year people in this class, the new MBBS students. Okay. Don't ask me that question in the medium, sir, why systole is this? That's why I'm giving you the chance slowly, even irritating the YouTube people who are watching my video. But it's worth to explain it slowly and slowly. Okay. Okay, now you are oriented. Now listen. If I subtract systolic blood pressure, if I give a difference of these two, systolic BP minus diastolic BP, it gives me a pressure that is known as pulse pressure. It gives me a pressure that is known as pulse pressure. So what is a pulse pressure? A pulse pressure is basically the difference between the systolic and diastolic pressures, not pressure. Systolic and diastolic pressures. So how to get that? What is the systolic blood pressure? We know 120. I hope you know this, isn't it? I hope you know this quantity, 120 by 80 mmHg. So 120 is systolic blood pressure. This is the diastolic blood pressure. So 120 minus 80. 120 minus 80. Why it's not writing? 120 minus 80. Yeah, now it's writing. So 120 minus 80 is equal to 40 mmHg. What? 40 mmHg. So 40 mmHg is the normal pulse pressure. Okay, fine. Now I want to tell you some things about this pulse pressure. You know, this pulse pressure is basically in some diseases. For example, I want to tell you a condition in which patient is having a high thyroid level. For example, T3, T4. He is having a high thyroid, which we call hyperthyroidism. Hyperthyroidism. You know, in patients of hyperthyroidism, what is happening is the patient is having more of systolic blood pressure. Remember, the patient has an increased systolic pressure and a decreased diastolic pressure. This should be a concept. In hyperthyroidism, the patient is having systolic blood pressure more than the diastolic blood pressure. That means the pulse pressure value will become more, because if you are increasing the difference here and you are decreasing this comparatively, and you will be having more pulse pressure. That means pulse pressure is increased in it. I don't say it will be definitely, but we have seen that it can be decreased in hyperthyroidism. Hyperthyroidism. Okay, fine. Or we have, I will be teaching you that aortic regurgitation. We have a condition, aortic regurgitation. In aortic regurgitation, the person has increased diastolic, increased systolic, if I can think, increased systolic BP and decreased diastolic BP. So that means again a high pulse pressure, again a high pulse pressure. Here also same was happening, increased systolic BP, decreased diastolic BP, giving us an increased pulse pressure. So at least you remember two conditions. I will be teaching you what is aortic regurgitation, but please write it. So aortic regurgitation, hyperthyroidism, in these conditions you will have a high systolic blood pressure and a low diastolic blood pressure, giving us a increased pulse pressure. I can give you a condition in which we have decreased pulse pressure. It's opposite, that is aortic stenosis. Aortic stenosis. In aortic stenosis, we have a decreased systolic pressure. We have a decreased systolic pressure. Cardiology is loud. Cardiology is loud. Okay. So decreased systolic pressure is seen in aortic stenosis. You have to remember this as a first year people. Otherwise, this is a big disease you have to learn in pathology and in medicine also. Fine. Is it clear, friends? Is it clear? Now, what is the mean pressures in your vessels? Any one of you can tell me? Since, see, if your blood is flowing through your systemic circulation, what is systemic circulation? Means I am taking more into account the peripheral blood vessels, more into account the peripheral vessels, not talking preferably about pulmonary vasculature, taking in all, some of all the systemic vasculature. What is happening? Your pressures will start decreasing because you are giving resistance, isn't it? You are giving resistance to blood flow. Pressure will keep on decreasing because you will be giving resistance to the blood flow. And pressure is highest in dash. I have taught you. Pressure is highest in which vessel? Aorta. Aorta. Aorta will have highest pressure. But where is the lowest pressure seen? Vena cava. Vena cava. So where do we see a largest little decrease in, will give me a largest decrease in the pressure? Where do I see that? Which vessel? That means I should check that vessel which is having the highest resistance. That means I should think of arteriole. So arteriole is having the highest resistance, meaning thereby there will be a large decrease in the pressure. I have taught you in hemodynamics. Go to the hemodynamics, CVS part 1, 2, 3, 4, 5, 6, 7. You have to check those videos to understand this word, what I'm speaking. Okay, no need to waste time here again. So largest decrease in the pressure will be seen at the arteriole because they are the places of highest resistance. They are the sites of highest resistance. So that means I should compare them here for revision purposes. Aorta, vena cava. Aorta will be having what pressure? 100 mmHg. What is the pressure in aorta? Mean pressure I am taking. Mean pressure. I hope you remember the mean pressure. Okay. Vena cava is only having 4 mmHg. Vena cava is only having 4 mmHg. Mean pressures, guys, we are talking about. Why it's not writing? It happens to this suddenly. Mean pressures, guys. Mean pressures. Aorta is having a mean pressure of 100 mmHg. Vena cava is having a mean pressure of 4 mmHg. Now what to put in between? So aorta, after that aorta, I come to arterioles. Arterioles will having what? How much? 50 mmHg. 50 mmHg is the mean pressure in the arterioles. And capillaries have 20 mmHg. Capillaries have 20 mmHg. This is so easy to remember. Aorta and vena cava make it first, then do the half of 50, then 4. There is nothing difficult if you take a smart your imagination how to remember things. Okay. Now, which pressure is highest during cardiac cycle? Which pressure is highest during cardiac cycle? So much time it takes, isn't it? Systolic blood pressure is the highest blood pressure. Which is the lowest arterial blood pressure? Diastolic blood pressure is the lowest arterial. That means in systolic blood, can I say systolic blood pressure, blood going in the arterial system? Can I say in diastolic blood pressure, things coming back to me, that is venous return. Venous return. Venous return. Is there any doubt in this? Who can't understand this? Please let me know. Don't feel shy. If you're not able to understand, please tell me. Is that the game happening in the brain? Can you think how heart is doing what? Is it coming in a picture form in the brain? How he will be sending and how will be coming? You should visualize. I suggest you to visualize. Don't remember. Visualize the heart and vessels in your brain. Okay. Who will be now determining this pulse pressure? By the way, who will be determining this pulse pressure? The pulse pressure is determined by stroke volume. The pulse pressure is determined by stroke volume. Stroke volume will determine the pulse pressure. Now what is happening is you are in the ventricular systole. If I talk about the left ventricle, in the left ventricle, ventricular systole, in the ventricle, okay, I am taking this left ventricle and this is our left atrium. Okay, this is left atrium, this is left ventricle. Left atrium, left ventricle. Now see, you have gates open, isn't it? This is a gate which is open, which you are sending to the outside. Okay, I will open a gate here. Okay, so you contracted this left ventricle. Okay, I show the contraction from this side because we have right ventricle from this side also. If I talk about the left ventricle, is attached to what? Systemic vessels. It is attached to systemic vessels. Now, once you are contracting the left ventricle and ejecting the blood into the atrial system, the arterial pressure will start increasing because arteries are behaving as lowest capacitance vessels. The arteries are behaving as lowest capacitance vessel. Who is having the highest capacitance? Dash. Highest capacitance is dash. Which vessel? Veins, venal system, vena cava system. It is showing that capacitance. Preferably vein system. I should not say vena cava system. So that means the arterial pressure will be highest. The arterial pressure will start increasing in the once you are doing the ejection phase or the ventricular systole. There should be a concept that diastolic pressure does not change during ventricular systole. Okay, there should be a concept that diastolic blood pressure remains constant. It is not changed during ventricular systole. The diastolic pressure remains unchanged. It does not change during ventricular systole. What will happen now? That means the pulse pressure will start increasing See, I will make like this. What was the pulse pressure equal to? Systolic BP minus. See, we said the pulse pressure is equal to the difference between systolic blood pressure and diastolic blood pressure. I'm explaining that word, that unchanged word. Okay. Now I am telling you this diastolic blood pressure. Once you are doing a ventricular systole, what changes? Diastolic blood pressure does not change. DBP does not change. Diastolic blood pressure does not change. Diastolic blood pressure does not change. That means whatever you do, this is the same. He's looking at you like this. He's there. There is no 50, 60, 70, 80. It's just whatever he is. He is whatever he is. In the ventricular systole, please listen to the word. I'm saying ventricular systole. During ventricular systole, diastolic blood pressure is not changing. That means whatever pulse pressure changes will happen, that will be corresponding to systolic blood pressure. Whatever the pulse pressure will be increasing, they will increase to the same level of the systolic blood pressure. Whatever level you achieve in the systolic blood pressure, the pulse pressure levels will start increasing by that factor only. There will be no need of thinking about diastolic blood pressure in case of ventricular systole, where diastolic blood pressure is remaining unchanged. The diastolic blood pressure is remaining unchanged. Second point, you know, once a person is aging, he is increasing with age. Basically, his pulse pressure starts increasing. Why? Because his capacitance decreases. That's the beauty concept. With aging, your muscularity, your vessels are not remaining that much elastic. Your vessels are not remaining that much elastic. It's aging process. And what will happen? You will be having a decrease in the capacitance. Once you have a decrease in capacitance, that means pulse pressure will increase. Definitely. I hope you understand. So in aging, we'll be understanding it in great detail once we go in more forwards. Okay, these are some points which I have to mention. So aging, in aging, what will happen? There will be increase in the pulse pressure. There will be increase in the pulse pressure because capacitance decreases. Capacitance decreases. Is it fine? Is it fine? By the way, did you understood this mean arterial pressure? Mean arterial pressure. What is mean? Mean. What is mean? Mean means it's we are taking an average. We are taking average arterial pressure with time. You are changing the arterial pressure with time, isn't it? You are changing this arterial pressure with time. Okay. How to calculate? DBP plus 1 by 3 pp. Do you know this? No. Okay. Mean arterial pressure, MAP, is equal to DBP plus 1 by third of pp. Is it clear? So if anyone tells you calculate the mean arterial pressure for me, what you need, you will be needing diastolic blood pressure and pp. But for pp, you will be needing SBP. I hope you understand. Because SBP, this equation SBP minus DBP will give you pp. And you need pp. Okay, pp done. Then even if you have DBP, you will be still needing SBP for pp. Is it clear? Is it clear? Okay. Now I want to take your concept. Now, after understanding all this, I want to take your concept towards something about the heart structure. Okay. The normal positioning of the heart I will be teaching you in the anatomy. Okay. But here I want to give the physiological concept. What is happening physiologically? Okay. Now, again, a small review for 2 minutes. This is your superior vena cava. Okay. Right atrium. And this is the right ventricle. Okay. Inferior vena cava, emptying the blood in the right atrium. Superior vena cava, bringing blood from the upper regions of the body and emptying it in the right atrium. Fine. So both are emptying in the right atrium. It's not the right ventricle, it's the right atrium. They are emptying the blood. And from the lungs, oxygenated blood is coming and it is finally, going into the right, through the pulmonary vein into the right atrium. So right atrium is connected to pulmonary vein and right atrium is connected at the back by the superior vena cava and inferior vena cava, which are emptying the blood. Wherever you find any doubt, please stop me there. Okay. Now I'm going so slowly. Whatever is my marker, please follow that. Okay. So that it remains in your brain in that way. Now, the mechanism is such that, to give you an overview of the mechanism, we haven't talked how blood is coming and going. Just giving you an overview, things come through the right, into the right atrium. Okay. In the right atrium, it has to open this door so that it can reach the right ventricle. And in the right ventricle, during ventricular systole, it will eject the blood into the pulmonary system. That is, it is going through the pulmonary artery into the lungs. You have two lungs like this. Okay. Same thing is happening from the lungs. The blood will come with oxygenated blood will come, and then it will drain into the left atrium, and from the left atrium it will enter into the left ventricle. But can you see the gates are open? Can you see these gates? Gates are open. Gates need to be opened so that blood can rush in. So now you tell me, please, if you want to rush the blood in, do you want the ventricles to be in diastole or systole? Do you want the ventricles at the time of filling to be in systole or diastole? Diastole. Very nice answer. And do you want these gates to remain open during diastole or closed during diastole? Do you want these gates to remain open during diastole or very nice open during diastole so that blood can rush in? The purpose is that. And should these gates close during ventricular systole or ventricular diastole? Should these gates close during ventricular systole or ventricular diastole? Very nice answer. They should close during ventricular systole. That means, can I say in the ventricular systole, the blood is ejecting out from the systems? Is it clear now? Because the gates are closing. There is no regurgitation. That is what is called regurgitation. That's why I was telling you regurgitation. If it goes in, normally in the ventricular systole, they should be closed. But if it is open, if it is incompetent, what will happen? Blood will rush into the right atrium. This is called tricuspid regurgitation. This is a tricuspid valve. This is a mitral valve. This is a tricuspid valve. This is the mitral valve. Orientation important. Right side of the patient, left side of the patient. Anatomical structures are read like that. We don't take our right as right. We take the patient's right as right. Is it clear? Everywhere, be it CT scan, be it X-ray, be it anatomy, be it dissection hall, be it any beautiful subject of medicine, you have to take the right side as if the patient's right side. So this is the right side, this is the left side. Right-sided valve, AV valve, is called tricuspid valve, isn't it? And this is the mitral valve on the left side. Fine. So we have learned two concepts. Sir, valves should remain open during the ventricular diastole, and valves should close during ventricular systole. Clear? Now I will talk about these valves. The beautiful thing about these valves is that they are maintaining. So can you see any direction going back into the valve? Can you see any diagram in this arrow showing any back direction from the valve? The valve is showing any reverse direction of flow. Everything is flowing in only in that direction only. Everyone is moving towards the sky. So that means this becomes the function of the valve. The heart valve make it sure that the blood flows in unidirection. Unidirectional. We also can say one-way flow of blood. Now we have four valves in the heart. We have atrioventricular valve. Which you call the tricuspid and mitral valve. So we have, if I talk about the valves, we have atrioventricular valve, okay, and we have semilunar valves. Atrioventricular valves, what I have? Semilunar. Wait, it's not writing. Yeah. So semilunar valves and atrioventricular valves. Atrioventricular valves. So atrioventricular valves, mitral valve and tricuspid valve. I should write like this, tricuspid, because it's on this side, right side. So tricuspid valve, mitral valve. Semilunar valves, aortic valve. Not taking aortic valve. I want to take pulmonary valve, pulmonic valve, not pulmonary. Pulmonic valve, aortic valve. So that means atrioventricular valve. So I should first think of atrium and ventricle. So two valves here. Tricuspid valve, mitral valve. Done? Done this? I should use this marker, okay? So tricuspid valve, mitral valve. Done. AV valve. Now, what is this ejecting into the systemic valves? Systemic valves I'm ejecting. I should not call it systemic valves. Just telling you that systemic circulation they are sending. So this should be the pulmonic valve, because pulmonary artery. This is pulmonary artery. So pulmonic valve. This is aortic valve. Is it clear, friends? Orientation is important. Then is the process is happening, how things happen. Okay. Should not lie like a patient. Okay. Don't lie like a patient. If you are not understanding, again, I will repeat for you. But this is a basic that even an kindergarten student can understand. That sir is showing this is aortic, this is aortic, pulmonic is pulmonic. Now, if I take the AV valves, that means what is AV valve doing? AV valve is not allowing the things to come back into the atria. AV valve is not allowing the things to come back into the atria. That means they prevent the blood from flowing back into the atria. In which time, at what time, that you have to speak. Ventricular systole. At the time of ventricular systole, blood is not allowed to go back into the atrium by the atrioventricular valves. Atrioventricular valves. Fine. Fine. Talking about the mitral valve. Talking about the mitral valve. If I talk about, okay, let me take tricuspid valve. Okay. If I take the tricuspid valve is not allowing the blood to go into the right atrium from the right ventricle during the course of ventricular systole. Now, second, mitral valve is not allowing the blood to go flow back into the left atrium from the left ventricle during ventricular systole. Are these two terminologies clear? Okay, this is also done. Second thing, if I take now these aortic valve and pulmonic valve, aortic valve and pulmonic valve, aortic valve. Now these both, what are these two? These are all what? These are all what valves? These are semilunar valves. So semilunar valves have a function. They don't allow the blood. Now tell me, once you are ejecting the blood has a tendency to fall. Once the pressure starts decreasing, the some of the blood at the back will try to move back into the ventricles. So you should have a valve to prevent this backflow. So that means I should speak like this. Semilunar valves prevent the backflow of blood into the ventricles. Can I say during ventricular diastole? Can I say the word ventricular diastole? During the course of ventricular diastole, when the ventricle is relaxing, once you are relaxing, you are creating such a negative pressure, you are decreasing the pressure, and this pressure, once it is decreasing, the blood which has already the last amount of blood which is present here, the column of the blood, it will has a tendency to fall down. It has a tendency to fall down back into the ventricle. So who is helping us? It is the pulmonic valve. It is the pulmonic valve which is preventing. So I should use now two words. The pulmonic valve is giving me a demarcation. Please listen to my word, what words I'm using. A pulmonic valve is giving me a demarcation between the right ventricle and the pulmonary artery. between the right ventricle and the pulmonary artery. True or false? Between the right ventricle and the pulmonary artery. It is giving a demarcation, a border. It is a border. Talking about the aortic valve is acting as a demarcation, a separation between the right ventricle and the aorta. Wrong answer. It is between left ventricle and aorta. Left ventricle and aorta. So can I say aortic valve prevents the backflow of blood from the aorta into the right ventricle, from the aorta into the right ventricle during the course of ventricular diastole? Why false? It's true. During ventricular diastole, that means this is relaxing. That means this, you have finished the ejection. You have finished the ejection. You have finished the ejection in the aorta. Aorta is this. This red color is aorta. Isn't it? So during the ventricular diastole, this valve will close. That means it is preventing the blood to move back into the left ventricle. Oh, I spoke right ventricle. Okay, I'm sorry. I'm sorry. Okay. Okay, fine. Sometimes a spelling mistake comes from my, I'm sorry for that. It's not intentional. Okay. I hope this diagram is making sense to you. This is also clear. Now I want to make you write fast at your, make a box at your this and write tricuspid valve is itself a tricuspid. It is having 3 cusps, right? Tricuspid valve is equal to 3 cusps. Okay. Bicuspid valve has 2 cusps. Please write. Tricuspid valve have 2 cusps. Sir, what is cusp? I will be teaching you. These are those pockets and nodules. I will be teaching you where in anatomy. This is not the task here. So have you written bicuspid? 2 cusps. Now write pulmonic valve. Pulmonic valve, 3 cusps. Pulmonic valve is a tricuspid valve. Aortic valve is a tricuspid valve. So who is only bicuspid? Who is only bicuspid? Mitral valve is only bicuspid. I hope you have understood. This is important once we are dealing with those aortic band structure, aortic stenosis. Beautiful cardiology, beautiful cardiology. See the architecture of the heart, how beautifully designed in your chest thoracic cavity, sitting and making you alive. Okay. So I hope this is clear. Now see the valves, they're working, they are doing the work, they are collecting the blood, they are receiving the blood, they are ejecting the blood. You know, they are producing some sounds. Okay. Okay, fine. I'm not getting any yes or no. Why? Because people are, I think, not understanding. Fine. Okay. Now see, listen to me. See guys, if I talk about the sounds, okay, heart sounds, I should use a new pen. If I talk about the heart sounds, they will tell me the image, visualizes, it helps me in visualizing the valve status. It gives me visualization of the valve status. I can think, I can think of valve status. Okay, valve status. So valve status in my brain. Okay, it tells me the valve status in my brain. Okay, so valve status, what status? Valve closure status. Valve closure status. Valve closure status. Fine. Or even if there is any problem with the valve, it will be telling me. This sound will clearly tell me. Now, I want to tell you first 2 principal sounds of the heart. Okay, guys? We want to make life easy. We don't want to, there are some people who start reading ECG from the beginning. First, my dears, understand how heart is working. The person who is slowly remaining perseverant in learning is the person who finally reaches the sky. And the person who jumps to concepts, starts reading, sometimes he takes that book, this book, he's always lost. He won't understand anything. We want to have a stepwise process. Even if we are working slowly and steady, we will do it. Okay, I can't see the race because I don't compete or I don't want to compete with anyone. Just raising your own standards. Okay, you have to increase your own standard, your own knowledge. That's it. Don't have to compete with someone. Okay, you have to deliver the best. Now see, guys. Now see, guys. Just look at me. It's so tasty, so tasty. Okay, I will be teaching you next lectures how to auscultate. Auscultate means listening to heart sound. So you should have a step. I'll be telling you later. So S1 and S2. First, I will tell you principal heart sounds. Principal heart sounds. These are called principal heart sounds. What are the principal heart sounds? We have S1, S2, S3, S4. Is it clear? S1, S2, S3, S4. Okay. Now let me tell you, first start speaking about S1 and S2. First, I will tell you about S1 and S2, then S3, then S4. Okay. Now listen to me. I want to first make you utter something so that it remains on your tongue for your lifetime. Once you are working as a doctor, it remains in your lifetime. S1 means AV close. S1 means close the AV valve. When your AV valves will close, they will produce a sound. Remember two concepts which my books have taught me. One concept, closing the valve. If a valve is getting closed, if a door is getting closed, it will produce a sound. Heart valves, if these are getting closed, they will produce a sound. Second thing, normal physiological heart valves, when they open, they don't produce any sound. In you and me, if we are normally hemodynamically stable, cardiovascular stability is there, we are functioning normally, you should not be able to produce any sound when your heart valves are opening. Fine. So closure of the valves will produce a sound. Closure of the valves will produce a sound. Opening of a valve normally physiologically does not produce any sound. If it produces a sound, it is a pathology, it is a disease. S1 sound is produced by closure of AV valves. Can you tell me which valves are producing S1? Can you tell me which valves are producing S1? Mitral and tricuspid. Mitral and tricuspid. Why you are writing only mitral? What happened? Are you having only view on the mitral side, left side? No. Heart is full. Sound will be full. Mitral, tricuspid. AV valves produce S1 sound on closure. In which phase? Early systolic phase. Once you have started to push the blood, what will happen? Once you have started to contract, you have contracted from both sides. Let me go slowly. You have contracted from both sides. What will happen? Definitely, sir, they should close this. The blood column should close it. It should get closed. It should get closed. Can you see how here he has shown very beautifully the valves are coming closer? If you understand this diagram, he wants to show you that, see how when blood is trying to move from this area, it is slowly narrowing its area. See, it is slowly narrowing its area. That's it's closing. That means it is closing. These are the AV valves. These are the AV valves which are closing. So which time they should close? Early systole or not? Yes, sir, they will close the early systole. Why? Because you have a rapid pressure at that time. What? Rapid pressure at that time. Early systole, you will be listening these sounds. Fine. Sir, where will you learn? Now, if you know the anatomy, this is the apex of the heart, and heart base is here. You always forget that. The base is here. This is the apex. This is the apex. So where will you listen to this? At the apex. Listen, S1 loud at the apex. S1 loud at the apex. So that means you have to learn the surface anatomy. Yes, I will be teaching you, because before auscultating, you should understand where is the apex, where is the right atrium, which space, which second intercostal, which third intercostal, mid clavicular line, which places you want to auscultate. You should know that, because this is what you will be doing for whole life, using the stat and checking every day thousands of patients, auscultating. If you don't know what is happening inside the heart, how can you auscultate? Even if you have learned it by heart at home, but you are not able to demonstrate us, that's a worry. That's a worrisome. Okay, so this is clear. This is clear. So that means, sir, the sound is not coming individually. Sir, the sound is basically plus this. Sir, it is a collection of T plus M. Can you say S1 is equal to T1 plus M1? Can we say it is a collection, both of them will produce an S1? Yes, sir, they will produce an S1. So that means an S1 sound has two components. That is how we learn things. S1 sound has two components: mitral component, tricuspid component. Mitral component, tricuspid component. We speak in this language: M1, T1, M1, T1. So easy concept if you are understanding the concept. Now, once you are respirating, see, okay, see, what is inspiration? Expiration, inspiration, expiration. So in inspiration, you are expanding your chest. You are expanding your thoracic cavity so that your lungs can get filled with air, atmospheric air. And at the time of expiration, you are emptying the lungs because you want all those acids to come out, isn't it? I hope you understand what I mean by acids. A carbon dioxide is basically an acid. Oh, I should not use a very basic language, because as being a medical student, you're speaking, your language also makes a difference on your things. So you have to understand many things while you are thinking about something. So I want to tell you one concept that is normally in me, during my all the time of respiratory cycle, during my time of respiratory cycle, this S1, these M1, T1, they don't vary. There is no variation in my respiratory cycle. I'm not saying cardiac cycle, respiratory cycle. These don't vary. They don't change. Okay. For example, what happens? A patient comes to you, a person comes to you, and he says, "Doctor," he is your brother. Okay. He says, "Doctor, he will say, I will make a situation like this. Doctor, I saw that my S1 splitted when I inspire." Okay. And or he says, my S1 split. Do you know split means these two split? Okay, they give you a time period. Okay, I will be teaching you the splits, but remember they split in some diseases. Okay, now if he tells you, "Doctor, hi, what happens once I inspire? I listen to the stethoscope. I feel that S1 has split. The M1 T1 components, they are varying. Okay, or he is showing you S1 split. In short, I want to tell you S1 split. It is not. You should get concerned about the situation. You should intervene. It's not normal. It's not normal. Is it clear? So normal respiratory cycle, inspiration and expiration, normal respiratory cycle, your S1 heart sound should not split. Is it clear? Now I want to tell you a minor thing. Maybe you have read it or not. Some books are, it's written in the books that mitral valve, the mitral valve, can you think in the brain? Mitral valve, yeah, it closes in little time period, approximately 0.01 second. Mitral valve closes earlier. How much earlier? 0.01 second, not even 0.1, 0.01 seconds than the tricuspid valve. That reason I will be telling you why that is happening. Okay, it's all about that venous return. He has to fill the blood and everything, or no, he has to send that blood to the that region. Okay, I will be telling you that. Don't worry. Just listen here. It will be closing just before the tricuspid valve. So mitral valve closes just before the. But once these both valves are closing, you will hear the sound as single sound. You will hear the sound as single sound. So you only hear S1 sound during, once you are auscultating, you will listen it as one sound. You will listen it as one sound. So remember, S1 is heard as single sound on auscultation. So once you close the mitral and tricuspid valve, or I can say atrioventricular valve, because they are between the atria and the ventricles, they will be giving me a one sound at a time. That sound is called S1 sound. Where is the S1 loudest? Apex. S1 is the loudest at the apex. Loudest, let me make it loud. S1 is loudest at the apex. Fine. The next story of S2 we will be continuing tomorrow, because today was the introductory lecture, because that's why it takes time. But yeah, it's worth it that you understand the basics first. Okay. I hope you have enjoyed this lecture. Keep enjoying cardiology with me. I would like to make it more interesting. Okay, because these sounds are, people say it's difficult, but once you understand, you keep in pace with me, I hope you will understand better. Okay, just believe me for some time. Okay, just believe in yourself also. Okay, just give me your 1% belief. Okay, so I hope you enjoyed this. Thank you very much and take care. Bye bye.